session 3 for our approaches to blue ribbon panel recommendations, focusing on Lynch syndrome, although we all should be talking about all high-risk cancers and hereditary cancers and how these approaches are all relevant. In this session, we are going to focus on Lynch syndrome testing approaches. And my name is Asad Umar. I'm co-chair with Kathy Halsazar, and I'm in the Division of Cancer Prevention, NCI. I did my research in Lynch syndrome before it was called Lynch syndrome, before we knew the phenotype as replication error phenotype. We identified microsatellite instability and DNA mismatch repair defects, so I did all the biochemistry and finding the defects and complementation groups before we knew the genes. I guessed, or based on the evidence, that there are at least 5 different complementation groups, and now we know there are 5 different genes. That was in '93 when we were working on that. That actually is the reason that I came to NCI after completed my postdoc. I came to Division of Cancer Prevention and became now the head of GI and the cancers group. And I'm very pleased to be working with Kathy and on this approaches to really figuring out our implementation ideas and picking all of your collective thoughts to come to some kind of agreement on what are the best approaches, how we want to move forward, what different scientific research questions are. So I will plead to everyone to please give time to people for discussion for the science and the research, and less to the description of their programs and things that can be found online, but by all means do talk about the relevant things. So the next session is the Lynch syndrome testing approaches. First, we will have Dr. Stanley Hamilton, who's going to talk about germline and tumor-based testing, MSI, and immunohistochemistry. Dr. Hamilton is a gastrointestinal and molecular pathologist. He's professor and head of pathology and laboratory medicine at MD Anderson. Dr. Hamilton has made significant advances in understanding the molecular genetics and genomics of GI neoplasia, Barrett's esophagus, and he also established the genetic progression models of colorectal cancer, has also helped identify molecular markers for screening, surveillance, prognosis, prediction of response and resistance to therapy, as well as new therapeutic targets. Then we will the next talk is panel tests and variants of uncertain significance, a very important topic that we haven't touched in detail. Dr. Zsofia Stadler is a clinical cancer geneticist and gastrointestinal medical oncologist at Memorial Sloan Kettering Cancer Center with a dual appointment with clinical genetics services and the GI Medical Oncology Service. She's an assistant professor of medicine at Weill Cornell Medical College, and our clinical focus is on the diagnosis, treatment, and management of patients and families with an inherited genetic predisposition of GI cancers, including Lynch syndrome. So after Dr. Stadler, we will have Dr. Sir John Byrne from he's a professor of clinical genetics in the Institute of Genetic Medicine at Newcastle University. He's going to talk about chemoprevention trials in Lynch syndrome. Dr. Byrne is well known for his number of cancer prevention, chemoprevention trials, the aspirin and resistant starch, CAP, cancer prevention programs. He's the chief investigator of the International Cancer Prevention Program, CAP, which includes CAP3 is a current trial that's ongoing, which is a dose non-inferiority study to determine the optimal dose of aspirin for cancer prevention in Lynch syndrome. In an earlier randomized trial called CAP2, that he demonstrated that aspirin reduces the risk of developing colorectal cancer in individuals taking aspirin for 3 to 4 years. He's the past president of European Society of Human Genetics. He's a past chair of Insight and British Society of Genetic Medicine. He's also non-executive director of NHS England and co-chair of BRCA Challenge. Then the final talk of that session is by Dr. Larry Brody. He's going to talk about ethical considerations in screening for hereditary cancers. Dr. Brody is the Director of Division of Genomics and Society at the National Human Genome Research Institute. As a bench scientist, he played an instrumental role in early and important discoveries about BRCA1 gene, which is responsible for a hereditary form of breast cancer. We all know that. His research efforts have regularly included studying the practical implications of genomics. Dr. Brody has also invested a considerable amount of his professional efforts to addressing the broader societal issues relevant to contemporary genomic research. This is a topic of number of questions in the earlier discussions. So with all that, now let me go back and on the agenda and ask Dr. Hamilton to start this session on germline and tumor-based testing, MSI, and immunohistochemistry.
Thank you, Assad. And thanks to Kathy and the rest of the organizing committee for the opportunity to participate. What I'm going to do is to cover a topic that you heard a lot about already this morning. That is the testing that needs to be done to identify patients with Lynch syndrome, and try to get into some of the issues that are more laboratory related. This is the part of the workshops and talks like this where people's eyes start to gloss over, but we'll hopefully have some interesting comments to make in regards to how this kind of work needs to be done in a high quality fashion. So this is the outline of the talk. Heard a lot of discussion this morning about yesterday's news with tumor testing, but as it actually turns out, it's tomorrow's news. This is a group from 4 professional organizations, as shown here: the American Society of Clinical Pathology, College of American Pathologists, Association for Molecular Pathology, and American Society of Clinical Oncology, ASCO, that have worked for 2 years on a set of guidelines using the Institute of Medicine, now the Academy of Medicine format for how to produce unbiased and evidence-based guidelines. This has not yet come out in print form. It is available online, and I'll show the reference again later on for those who want to look it up. But a great deal of what I'm going to be talking about is included in this paper. Very little of it actually relates to the genetics, and we're very proud of the fact that this is, as far as we can tell, the only guideline of this sort that has moved into the laboratory aspects of quality control and processes to deliver results to patients, and not emphasized solely the relationship of the gene mutations themselves to the clinical alterations. So universal testing of colorectal and endometrial carcinomas, we've heard a lot about this already. You've already seen this slide with the 3% number on it, but the reason for showing it here is that it's a little different than what you heard about this morning. This directly affects tests that are going to be used to try to determine the presence of this or any other disease, that the frequency in a population has major influence on the sensitivity, specificity, and predictive values that occur with laboratory tests. And so because this is a rare tumor in the population, even at 3%, there's expectation that there's going to be a low yield of screening. The complexity of the syndrome has already been talked about because there are multiple cancer types involved in Lynch syndrome. The disease is familial, but again, as you heard about this morning and saw some pedigrees up on the screen, in contrast to what we worked with 20 years ago, where there were big families with lots of SIBs to look at and try to look at linkage and this sort of thing, the size of families is decreasing, and this further complicates how to try to identify the kindreds that are affected with this. Again, as you've heard about earlier, there's major impact on patient and family members for this testing, and so it has to be highly accurate because you're now dealing with people who are asymptomatic, and you want to be sure that you're delivering the appropriate information. Again, the topic of the incomplete penetrance has been mentioned multiple times this morning, and this again is another issue. The pathology has been mentioned briefly, and I'll show some examples of that. It's characteristic, but certainly not diagnostic of the presence of the condition. The molecular mechanisms, at least, are well characterized now, and that's what's led to the availability of tests So we have the options now to choose from a variety of different ways of trying to identify the condition. And furthermore, there are more in the pipeline coming to us. The methodologies that are available all have advantages and disadvantages to them. And again, we're going to talk about that. So the universal testing, you've heard this again this morning, EGAP 2009 put into effect in 2010. The National Society of Genetic Counselors and the Collaborative Group of the Americas recommended this a number of years ago. And now in this professional organization guideline that is out, we are again recommending this, and there are plenty of others. I'm not to insult anybody, but there are a number of organizations that have now recommended going to this. This discussion again this morning in terms of how to do this, the universal testing of the tumors is not only about Lynch syndrome anymore, and that's a key element to this. The testing at the beginning was largely directed after the pathogenesis was recognized in trying to identify patients using the microsatellite instability testing in tumors. But it took a fair amount of time, but now has penetrated into the general medical practice. Initially pointed out actually by Henry Lynch, Patrick. I don't know if you remember that from your dad, but in looking at those families and recognizing that the survival stage for stage was better than it was in the general population of patients. And subsequently now, with a large number of studies done, it's clearly recognized that microsatellite instability is a favorable prognostic indicator. In addition, it also influences now adjuvant chemotherapy decisions, widely recognized with the better prognosis, and also in particular poor response to monotherapy 5-FU, no longer recommended for stage 2 patients. And as you heard from Frank Sinecrope this morning, there's now a trial underway in stage 3 colon cancers in the adjuvant setting to determine if there is in fact going to be improvement with adjuvant therapy in that setting in the MSI part, or if we'll be able to save adjuvant therapy effects on patients because of lack of benefit, to be determined. There's also old literature on chemotherapeutic agents in this. It was looked at back in the 1980s, and the cell lines with high levels of microsatellite instability were shown to be exquisitely sensitive to irinotecan to a greater extent than many other of the agents. And there are data from one clinical trial retrospectively done that showed better survival in patients who got an irinotecan regimen with microsatellite instability high tumors than with other regimens that were in that particular trial. It's C80403 from CLAGB if you'd like to look that up. And then finally, again, mentioned multiple times this morning, the direction of immunotherapy, and this area has exploded. We're being asked to do microsatellite instability on almost every tumor that seems to come through our laboratories now, trying to look for patients who have hypermutated tumors that may be susceptible to immune therapy blockade. In addition, there's also the issue of cost effectiveness with this in terms of how we do it. And again, this is going to be discussed later on in the afternoon, of the ethical, legal, social, and psychological issues. And you heard some of that this morning from Heather in regards to the impact of testing on patients. The other issue is what are we going to do in terms of going beyond simply colorectal and endometrial cancers. Colorectal adenomas, there's some initial data, again, coming from the Ohio State group showing that microsatellite instability can be detected in the subset of the adenomas in these patients. And in addition, you've heard this morning about the other Lynch-associated tumors based on the clinical findings that need to be tested as well. The fact that this has penetrated into medical practice is indicated by this. In the 2010 WHO classification of tumors of the digestive system, it was recognized that the old traditional category of poorly differentiated mucinous adenocarcinomas being classified as high grade did not apply in the microsatellite instability setting. That the prognosis was sufficiently better. The WHO actually moved those MSI high subtypes of tumors into the low grade category, no longer high grade. So in terms of the tumor-based methods for Lynch case finding, again, we talked about this a lot this morning, and this again relates to what the characteristics of the tumor are that have been defined. And this is from a follow-up study from the TCGA. And as you can see over here, this is the MS high group here, and if you look up to the top, you see that there's this clear break in the number of alterations at about 12 per megabase that occurs in the hypermutated group. and the subset that is not MSI high is the Pol E and Pol D mutated group. That's the small group here. But again, well recognized that these tumors have a huge mutational burden associated with them. And if you look at this in relationship to the types of mutations, not just the number of mutations, but the types that occur, if you look at the top 25 genes that have recurrent alterations in the TCGA database, 9 of those are expressed in the hypermutated group and 19 in the non-hypermutated group. And 4 of the most frequently mutated groups are present in both subtypes, but at different frequencies. And here the ranking of this. This is the rank from 1st to 6th of the genes in the non-hypermutated group. And as you can see, the KRAS, the most common in non-hypermutated, is only 4th in frequency in the mutated group, and on down the list here with the BRAF and TGF-beta basically well down the list in frequency in the non-hypermutated, but common in the hypermutated subset. In addition, if you look at the other molecular alterations that are present, here's the MSI group shown here, and all you have to do is cast your eye across the types of alterations that occur, and you can see this is a very different set of alterations in terms of structural changes that occur in the genome. Again, long-standing recognition of that particular difference. So we have a number of clues as to how to go about testing these tumors and things that we can look for to be able to define this group. And so again, the workflow has been around for a number of years of trying to look at the presence of methylation, the gene frequencies. BRAF mutation was mentioned this morning as being commonly, far more commonly present in the cases that are sporadic as opposed to the ones that are in Lynch syndrome. Again, can be helpful in identifying what's going on in the tumors. So again, it's worthwhile a quick look at the history of this, and a lot of this has been discovered this morning, so I'm going to fly through this. But initially, obviously, we were talking about personal and family history being selection criteria, and then trying to move on to genetic testing to define the cases. I really like this diagram. This was mentioned this morning, but it shows very nicely, if you look at the box here of the MSI high tumors in relationship to the predictions from the Bethesda criteria, or the prediction mechanism, the Bethesda criteria associated with MSI, what you see is the Lynch syndrome group is this small box in the midst of this, and there are lots of false positives as well as false negatives outside of within the MSI group that obviously don't relate to Lynch syndrome, but yet get identified by these various mechanisms. So clearly the need to evaluate the tumors. Pathology, again, was mentioned earlier on by Patrick and others, and I'm not going to go through this in any detail, but these tumors very commonly have mucinous histology and this Crohn's-like lymphoid reaction with lymphoid nodules with germinal centers and marked desmoplasia around the outside of the tumors. This is the so-called medullary subtype with numerous intraepithelial lymphocytes within poorly differentiated tumors. And this subset, very rare subset of the pure signet ring cell carcinoma is almost always microsatellite instability high from the pathology standpoint. In addition, the recognition that the precursors are a bit different, that the sessile serrated adenoma polyp in the right colon is a common precursor to these tumors. It's not a one-for-one relationship. It isn't either or compared to a traditional adenoma, but these are obviously more commonly associated. So if we move to the present state of how we recognize the tumors now, basically, as you've heard over and over again this morning, it's immunohistochemistry looking for complete loss of nuclear staining in the tumor with retention in the non-neoplastic cells. And again, this is a key element. There are a number of problems that occur with immunohistochemistry testing in this for the people who are not necessarily aficionados looking at it. The first thing to look at when you get the tumor is whether the normal lymphocytes and normal epithelium in the specimen are staining. And if they're not, you throw that slide away and start over. And unfortunately, we periodically get cases that have been called absence of mismatch repair gene, when in fact it's a technical problem with the staining. So the immunohistochemistry has the usual issues associated with that technology. You can look at the effects on the DNA, and again, as you've seen earlier in the day, the alteration of the allele links. And in addition, we can then move to looking at possible mechanisms, as you've already heard about, the methylation of the MLH1 promoter and BRAF mutation, methylation being, and BRAF mutation being very uncommon in the Lynch syndrome patients, but again, not perfect. There are Lynch syndrome patients who do have BRAF mutations, and there are also some who do have significant methylation in their tumors. Again, you've heard about the tumor sequencing this morning, and beginning to look at that as a potential way of evaluating these. And finally, the approach to taking germline sequencing, in particular in relationship to the tumor DNA next-generation sequencing that's now being done. Many laboratories, including ours, are now running a non-neoplastic DNA control along with the tumor. And so we are detecting those germline alterations as part of the routine testing that goes on when we're doing the sequencing of the tumors. And again, mentioned again this morning, when you're specifically looking for the germline alterations, well recognize that there is low sensitivity of most of those assays for the large deletions and rearrangements that occur in the germline of Lynch syndrome patients. And you heard the discussion this morning. It looks like Lynch syndrome, but the testing is negative. What do we do? Now, this is what the immunohistochemistry looks like when it's working the way it's supposed to. So this is a poorly differentiated tumor. It's got a lot of tumor-infiltrating lymphocytes in it, and you can see the nuclei in the tumor are dead negative, and you have the nice built-in control of the lymphocytes in the periphery of the tumor that shows you that the stain is, in fact, working. The difficulty with the immunohistochemistry piece of this and the pathologists, and again, we appreciate the comments this morning about the importance of pathology in this, but this is also a problem for us, because it has broken the workflow in terms of the way we do business in pathology laboratories. That having to go through and do these markers and get the information back together and the information in the appropriate format to the clinical people who are making the decision, having to send it multiple places to make sure everybody who needs to know about this, from the gastroenterologist, the GI surgeon, the geneticist, the medical oncologist who's involved in the patient's care, puts a strain on a number of our systems, including our information systems. And again, the other issue to this also is how this is done. And you heard this morning, that different places are taking different approaches to what they do with the testing. So here's one that starts with the MSI immunohistochemistry and then breaks down to this very complicated algorithm of adding on the sequencing at the DNA level and the methylation, that sort of thing, to figure out what's going on in the patient. We, from the pathology standpoint, have not been doing that for more than about 5 to 10 years now, and it's a problem. And including the fact of starting off with the original material, the starting material, which is often in somebody else's laboratory or in our warehouse when it comes time to get the testing done, involves in having to retrieve specimens from elsewhere or from our own files. So again, as you go through and look at this, here's another approach that uses patients under 70 as the starting point. Another one again here with a different set of approaches to the testing. Here's one that goes to the BRAF alteration immediately after loss of MLH1. And again, with the loss of any of these, here's the initially negative test, and then you're going to go and evaluate the molecular pieces of it. So again, even if you look at the literature, you've got a huge number of differences in this. So the assays are based on the pathogenesis of the syndrome, and again, shown here, germline mutation that has a second somatic event, loss of the functional protein and loss of its binding partner, failure of mismatch detection as a biochemical event, then the failure to repair the DNA, and finally replication of the altered DNA. And these steps, as indicated here, are susceptible to detection by sequencing, immunohistochemistry, and PCR amplification. Now, in terms of the comparison, and again, this was talked about a fair amount this morning, and I think these points have been well covered. There is one here related to the cost. It isn't just the cost, it's also the reimbursement. So if we send through an immunohistochemistry to a third-party payer, they usually don't turn a hair. If we start talking about DNA testing and this kind of approach, all of a sudden there's discussion about pre-authorizations and, what is this being used for, and immediately throws a wrench into the gear. So again, one of the advantages, not simply that are listed on the slide here, but we are much more likely to be reimbursed for immunohistochemistry than we are for the molecular test until the data really begin to accumulate that this molecular testing is needed. From the standpoint of the immunohistochemistry, there are some surprises out there. This is a pattern that shows up periodically. You've seen the criteria published, and it's everywhere. It's loss of the expression in the tumor nuclei. Well, the fact is, in some of these subsets, there's this peculiar speckled pattern that occurs with MLH1. You can see the tumor-infiltrating lymphocytes in the periphery with this solid pattern to the nucleus. But notice here in the tumor cells, it's got this speckled pattern. And sometimes this is actually relatively dense and begins to look like a positive nucleus. These cases, when you look at PMS2, its binding partner, there's no PMS2 binding. In these cases, our microsatellite instability high. So again, there are clonal changes within tumors where there's loss in one area of the tumor and not in another that periodically occur, and the interpretation of these is not a straightforward plus-minus into the discussion. So to summarize the algorithms, the MSI testing has wide variability in the literature. Patient selection, use of predictive algorithms, informed consent, lab methods, steps in the evaluation process, highly variable. And it would be very helpful if a decision could be made based on levels of evidence of how these ought to be done. And again, at our institution, we start with immunohistochemistry for the reasons that I explained, and then move to a 7-gene panel, and then reflex tests of the BRAF and methylation of MLH1 as needed. Future prospects, again, other things that can be looked at, mutational burden, lots of discussion about that, and also being able to profile the characteristics of the mutation, particularly in these panels where we're doing 150, 200 genes to look at the types of mutations that are occurring within them and what genes are involved, changes in expression pattern, obviously the immunocyte populations in reaction to the neoantigens that are generated by the high levels of microsatellite instability, and the development of algorithms to predict the presence of neoantigens in that setting. Germline testing has already been has been covered. I'm going to skip by this and go to the last point. One of the issues with our guideline was to look at the quality issues with this, and this is the key piece from this paper. It's the 21 recommendations. And as you look at those, there are 22 statements and 22 recommendations and 21 statements within this paper. 3 of these specifically address microsatellite instability testing. That is the recommendation that it be universal, to validate the performance of the immunohistochemistry in accordance with best laboratory practices, not something you read in any of the other papers that are out there. And finally, BRAF V600 mutational analysis with loss of MLH1 to try to define whether the patient is sporadic or has Lynch syndrome. There are 5 that are related to prognosis and predictions of response to therapy. But what I want to particularly call attention to is this. 14 of the recommendations address methodological issues related to the quality of the testing. And this is a key element to it. And again, this covers everything from the specimens being used, that it needs to work in formal and fixed paraffin-embedded tissue, that the methods need to be validated in an appropriate fashion, that we have to have, from the laboratory standpoint, appropriate turnaround times. Now, you think this would be a slam dunk, but again, a lot of pathologists got real uneasy when we started to talk about that these needed to have the results back within a set period of time to the clinical people because of these problems related to the workflow and where are the specimens. Again, the sensitivity of detection, and here again was the one that caused significant controversy. 90% of the results should be returned within 10 days. Again, from the standpoint of interpretation, our reporting needs to be better. If you look at our reports that go with these things, they're often hugely different from one institution to another, and the clinicians who are getting these from companies, from the labs in their own hospital, et cetera, often have to face the facts of these differences. So what I've tried to do is to go through this outline relatively quickly. I hope we'll have time for some further discussion of it, and from this point we'll move on, and I thank you for your attention.
Down. Perfect. Perfect. Up. Sure that's not. Yeah. Let you down. Here you go. Great. Thank you. Good afternoon. It's a pleasure to be here, and I especially want to thank the organizers for their kind invitation. So I think we have heard quite a bit about multi-gene or multiplex panel tests this morning. I think there is a mixture of both excitement and trepidation about what these panels may bring us, and I hope to address some of this today. So Up to about 4 or 5 years ago, our approach to cancer genetic testing has really been single gene testing, and this is where you have a specific tumor in an affected patient or a specific cancer phenotype. This generally drives you to consider testing for 1 or maybe 2 different genes, and this has certainly been the standard for Lynch syndrome. The IHC abnormality or the MSI high status would dictate your germline testing, and this very well fit into the model of genetic counseling, where you have pre-test genetic counseling for a single gene or 2 genes and subsequent testing and then post-test counseling. And of course, if negative, then the patient may require some sequential testing subsequently. However, over the last few years, with the advent of next generation sequencing, the multi-gene panel testing has become pretty widespread. It's available through a variety of different commercial companies. And this is essentially simultaneous analysis of a set of genes. And this set of genes may be quite variable. They may or may not be associated with a cancer-specific phenotype, as was pointed out already earlier today. So, and it was around the same time that with the advent of next-gen sequencing, the complexity of colon cancer susceptibility began to be sort of became more obvious to us. So in addition to the Lynch syndrome genes that are demonstrated right here, in addition to the adenomatous genes like APC and autosomal recessive MYH, there are now a number of novel genes associated with adenomatous polyposis. For POLE and POLD1, the clinical phenotypes are still being elucidated. GRAM1, probably with a mixed polyposis picture. And then, of course, there are the low penetrance colon cancer susceptibility genes. Probably the 3 most common are CHEK2, the monoallelic MYH, and in the Ashkenazi Jewish population, the presence of APC I1307K as being associated with probably about a 2-fold increased risk in colorectal cancer. So because of the both the advent of multi-gene panel testing becoming technically feasible and because of the expansion of the colon cancer susceptibility genes that have been implicated, there are now a number of these panels that are available at commercial companies. This is not an all-inclusive list, so some companies are clearly missing here, but what you'll see is among these 4 specific companies, they basically all include the high penetrance colon cancer predisposition syndromes, but then you will see that they include a variety of other lower penetrance colon cancer genes, and the number of genes included ranges from about 15 to upwards of 25. In addition to these colon cancer-specific genes, earlier today it was also mentioned that there are the pan-cancer genes that can include as many as 60 to 80 different genetic genes. Some of them associated with high penetrance and some of them with low or moderate cancer risk. And many of these are not associated with colon cancer, but can still be tested in colon cancer patients. So what are the advantages of these panel tests? Well, certainly they improve efficiency, which I'll point out. They may be cost-effective, and potentially incremental findings of genetic susceptibility have been identified. And I put a star to it because I think this is one of the advantages and one of the potential challenges. So certainly improved efficiency. In many families, you have personal and family history that's suggestive of multiple syndromes. In this case, when you need to test for the breast cancer genes and the colon cancer genes, certainly a multi-gene test makes sense. Genetic heterogeneity, I think this is becoming more and more the picture in patients with colon cancer with polyposis. Differentiating between APC, MYH, POLE, POLD1 is becoming very difficult. So as for similar phenotypes that can be caused by a variety of genes, multi-panel testing certainly makes sense. Of course, when there's no tumor available, then which gene do we start with if there's a strong personal or family history? And this is relevant for affected members where they have a colon cancer but the tumor is not available for testing, or in unaffected family members where the family member with the tumor is deceased and the tumor is not unable to be located. Of course, there's a decreased turnaround time, generally speaking, although I still find that in my pre-surgical patients who are at high risk for Lynch syndrome, we still use IHC from the colon biopsy and proceed with germline testing for the gene corresponding to the IHC abnormality. As we do that test in-house, that comes back within probably a week, while the multi-gene testing may take a couple of weeks to come back. And then also, as Heather had mentioned, decreased patient visits and number of tests. So there is this idea of testing burnout, especially in the colon cancer patients, as you have patients come back repeatedly for additional genetic testing. So in terms of making the case for multi-gene testing, this is that patient that I recently saw, a 40-year-old man with ureter cancer and also colon cancer. He presented with an obstructive sigmoid tumor, was emergently taken to the operating room, and his tumor was a stage 2A tumor, and IHC was normal. But given my concern for Lynch syndrome for the obvious reasons, we did some further testing. I should mention that he also underwent a post-surgical colonoscopy, which showed 16 tubular adenomas and 3 to 4 hyperplastic. So I wasn't sure, was this Lynch, was this polyposis, what was this? And so we did a multi-gene panel, mostly including genes with colorectal cancer, and found the POLE mutation. This is one of the hotspot mutations explaining his family history. I don't think POLE would have been my #1 choice, so with sequential testing, this would have taken a while to figure out. So in terms of cost effectiveness, there are not that many studies on this. There is one study that was published about 2 years ago in JCO, which was a decision model to evaluate NGS panel testing, and it calculated the cost and health benefits of identifying relatives with a pathogenic variant and quality-adjusted life years. And what they found is that an NGS panel that included the Lynch genes, the 5 genes, and high penetrance autosomal dominant and autosomal recessive, some by age, genes was cost effective. Testing only with the Lynch genes was not, actually. It was very interesting. The QALY was $144,000 for just testing the Lynch syndrome genes. But if you include the other high penetrance genes, then all of a sudden you have a cost-effective test. Why is that? Because of the downstream cascade testing and the prevention that this poses for family members. The addition of low penetrance colon cancer genes wasn't particularly helpful. The incremental cost-effectiveness ratio was about $77,000. That was the only study to date on NGS panels in colorectal cancer that I'm aware of. So what about incremental findings? So I think we're all excited about this aspect of it. I think I'm going to rush through this, as Heather already very nicely summarized some of this data, but she did evaluate 450 colon cancer patients aged less than 50 and identified 16% with germline mutations in one of the 25 genes. Again, this 25-gene panel, as she pointed out, was not just colon cancer. It also included BRCA1, BRCA2, PALB2, et cetera. As expected, 8% had Lynch syndrome, which is sort of consistent with the early onset colon cancer cohort, and 2.4% had low penetrance colon cancer susceptibility genes like CHEK2, APC13, I1307K, et cetera. And then 2.8% had genes not traditionally associated with colon cancer. This included both the high and the moderate penetrance genes. Interestingly, about 33% of patients did not meet established genetic criteria for the gene in which the mutation was identified, so it was an incremental finding in those patients. Similarly, Dr. Erglund, very recent JCO paper was a wonderful study as well. This is a clinic-based colon cancer ascertainment. It was a retrospective analysis using a 25-gene panel of consecutive colon cancer cases at a tertiary cancer institute, but it was not much less biased in terms of age and in terms of who underwent the testing. And in fact, 10% of these patients were identified with a pathogenic mutation, with about 5% in the high penetrance genes, about 4% in the colon cancer associated, and 1% BRCA. Moderate penetrance, about 4.7%, with about half due to, or 3% due to known colon cancer susceptibility genes, moderate penetrance, and 1.5% due to genes not associated with known colon cancer susceptibility. So in our at Memorial, what we have done is a tumor sequencing panel, which includes 410 genes. Some patients consented it. And as a part of this study, we also had patients consent to a germline analysis of 76 of the 410 genes that are on this tumor panel. The tumor and the blood are run parallel, and in the tumor results, the germline result is actually subtracted out. We found that 17.5% of patients had an actionable mutation, and over half of these would not have been identified, and most of these pickups were, interestingly, in biliary, prostate, renal, pancreas cancer, and colon cancer. About what we noted is about 5% of these cases were hypermutated or MSI high, and of those, 23% had Lynch mutations. But of our total 14 Lynch patients in this 1,000 patient population, two had an MSH6 mutations whose tumors were not hypermutated, and 6 were incrementally detected by germline analysis in the absence of a family history diagnostic of Lynch syndrome. So this sort of tells you that there may be additional cases of Lynch out there, especially non-canonical tumors. So 3 of these cases were in prostate, and the other 3 were in urothelial cancers, where we're probably missing some pickup rate. So where do we go from here? So I think we have shown that we do get incremental findings with panel testing. And do we have analytical validity for these panel tests? Yes, I think we do. We're able to accurately and reproducibly measure this genotype, and the commercial lab had to prove that prior to starting this testing. In terms of clinical validity, our ability to accurately and reliably predict disease or outcome, we usually do, but probably not for all of the moderate or low penetrance genes that are included on some of the really big panels. But then last but not least, what we're really unsure of is, do these tests, do they result in improved clinical outcomes for our patients? And I think the way I think about this is I break this clinical utility down into 4 potential different categories of genetic results. So there are your high penetrance genes and your lower moderate penetrance genes, and certainly clinical utility has been proven in the patients with high penetrance genes associated with the phenotype at hand, in this case colon cancer. What about in patients of high penetrance genetic mutations in cancers that are not, in genes that are not traditionally associated with colon cancer susceptibility? So these are the 1% BRCA1, BRCA2 findings from Heather and Matt's paper. I think there is clinical utility there, but there are a lot of unanswered questions that were pointed out by Dr. Lynch and Dr. Boland this morning. What is the penetrance in these patients? What's the age estimate? When are they at risk? And are these potential new associations to colon cancer, or are they just incidental findings? So is it really above the population rate? And then what's more challenging in terms of utility is the low and moderate penetrance genes. So in terms of CHEK2, APC 1307K, I1307K, is would you change management because of the presence of any of these moderate gene colon cancer susceptibility genes in a patient who already has colon cancer, and where the family members will already have increased screening and surveillance based on the presence of that colon cancer? And then the 4th category are the low and moderate penetrance cancer genes that are not associated with the phenotype at hand. So this is your ATM and BM mutations. What do we do with those patients? So in terms of the other challenge of multiplex testing is the variants of unknown significance. I think we're all familiar with the characterization of these variants. It's very important to know what to do with a variant and whether it can be reclassified, because it has implications for pre-symptomatic screening, timing of prophylactic surgeries, and of course predictive testing for family members. The VUS rate is very variable, 15 to 42%, depending on how many genes you test, what types of genes you're testing, and the patient population. In Matt and Heather's study, the rate was roughly 30%. So Insight has done a fantastic job of trying to categorize these variants, which is outlined here, and this was mentioned by Dr. Linder. What you see is actually with the old classification, a number of what were classified as pathogenic mutations were actually reclassified as class 1, so as not being pathogenic, and on the flip side, a number of variants that were initially classified as not being pathogenic were actually reclassified as classified as truly being pathogenic. Almost there. ClinGen is another research for putting in genetic variant results through ClinVar, and as part of the hereditary colon cancer ClinGen panel, we're doing a lot of work on trying to associate clinical validity and clinical utility in some of these moderate penetrance genes. And then last but not least, there is a database called the Prospective Registry of Multiplex Testing that's a collaborative effort through a number of actually commercial laboratories as well as a number of academic institutions looking at the variant results, especially in the moderate penetrance genes. And one of the first results coming out of this, of the PROMPT registry, is of the 603 variants that were put into the system, about 40% were VUSs, and the interpretation differed among laboratories in 26% of cases. In fact, 11% of patients had a variant with conflicting interpretations ranging from pathogenic or likely pathogenic to VUS. So so it's a discrepancy where your medical management actually would have changed based on the interpretation of that genetic alteration. So I think this is really important to keep in mind when we're evaluating results of multiplex genetic testing. So to conclude, multi-gene testing is here, it's efficient, and it's likely to be cost-effective, but who should get it? So should it be in addition or in lieu of tumor testing? And I think what Heather was saying is maybe it should be in addition. Is it necessary for all colorectal patients or just early onset? And if we offer a panel, which panel is a bigger panel always better? I think we need to really carefully think about the clinical utility aspect of that. And what do we do with the off-phenotype findings? For example, the penetrance of the PMS2 genetic alteration in a non-colon cancer family that Dr. Lynch had mentioned. And VUSs, they certainly remain a challenge, but I think we have a lot of resources that have been put into place through Insight, Prompt, ClinVar that will help figure out the interpretation of these variants. Thank you.
Well, I said, ladies and gentlemen, thank you for inviting me to this fantastic meeting. I've been given 15 minutes to do chemoprevention, and then last week I said, so can you do vaccination as well? So I'm going to move swiftly on. And I should have learned how to actually drive this thing. Do I just use? So the only disclosure I need to mention is that I'm talking about work done over the last 25 years, which has been largely funded by Cancer Research UK and the MRC in England. But Bayer Pharma have supported us throughout, providing the aspirin and logistical support. Back in the 1980s, I was wingman to Nick Wold in the folic acid work, showing that folic acid prevents spina bifida. And about the same time, I'd become drawn into FAP and realized that we could actually do a similar approach. And we set up the first randomized study in FAP patients. The idea being these being patients who are highly motivated. We knew what caused their cancer. They're already under surveillance, and because they got so many problems, we shouldn't need so many of them. And we got a European grant to kick it off, and that's now become the Cancer Prevention Program. But just as we began that study, I was involved with Tim Bishop and Nigel Hall in his lab mapping Ted's family. He had colon cancer 3 times. He was a shepherd. And we just mapped it to chromosome 2 when the word came out that Anne Green's family had been mapped to the same place. And we gave out Ted's DNA to Richard Kolodner and Rick Fischel. And in fact, I think probably were the first people to actually do a diagnostic test. So a few weeks after the Cell paper came out, we did the first predictive test in Ted's family. And that immediately, of course, made me realize that this is a much better target population for chemoprevention than FAP, where you've got 1,000 polyps. It's really difficult. We had to video record and so on. And so we started setting up CAP2 in 1994 and began recruiting in 1999. I foolishly thought that by the time we got the grant in place, everyone would be doing this and there'd be thousands of people to recruit, and of course there weren't. So we had to go all over the planet to find our 1,000 gene carriers. We had a very exciting time. Sao Paulo was great because our little packets of starch powder were impounded by the customs. They didn't like the look of these little plastic packets for some reason. So we never got any patients from Sao Paulo. And we didn't get, Henry Lynch and I put in 2 bids to set up here in the States without success, but we're not bitter. So we got our 1,000 carriers being age 45. We treated them for 2 years, and then because it was so slow, we actually asked them to stay in for a further 2 years. So some of them did 4 years, and it was an average of about 29 months was the mean duration of treatment. And you've already seen this graph from Patrick. The weird jump at the end was just because we had almost no data. And at the AACR meeting that Andy Chan has organised, I'll be presenting the final 10-year follow-up data, which we've just now got. The last patient started in 2006. And the important thing was that this was a planned 10-year follow-up. We always knew there would be a long time before we saw the cancer prevention effect. And the other point being, of course, the point raised earlier, that 20% of the people in the placebo group got cancer. And although Rick didn't want me to tell you what he thought about colonoscopists, apparently, the fact is that this can't just be poor colonoscopy. These were expert centres. The fact is these cancers pop up at remarkable speed and in remarkable numbers despite having all their polyps removed. And this effect was also apparent. The hazard ratio was 0.41. The incident rate ratio, which takes account of multiple primaries, so it's a Poisson distribution, was even more significant. But this is in the per protocol data. It wasn't quite significant in the intention to treat, because, of course, a lot of people started and then dropped out, mainly because the starch limb of the trial, which was giving 30 grams of starch every day to add to their diet, was quite a challenge. But the 600 milligrams of aspirin didn't present any major problems for the patients. And interestingly, there was a non-significant difference in bleed rates between the aspirin group and the placebo group, because these were relatively young patients. And that's the Lynch data, which is basically the same. So we published the paper in 2011, and Laney said that we'd hit a home run. It was true. We've had more than 500 citations now. And this was the take-home message that most of you are familiar with, that basically, coming back at 5 years after randomizing these patients, we had an over 50% reduction in cancers. And I was very pleased to read the American Gastroenterological Association assessment, that they called it a high-quality randomized controlled trial, then spent a long time saying how bad it was. But the important point was that they pointed out quite rightly that the dose we used was high. Now, that was a very deliberate decision based on good pharmacological practice. We went as high as we dared because we had no idea what dose to use. And Richard Dull used actually 1,200 milligrams in the original cardiovascular trial. And so the idea was we'd start high and then pull back to see if we could get the same effect with smaller doses. Before going on to describe how we're doing that, just to emphasize an important point, this is a paper that we published last year, or 2015. And this is basically looking at obesity in the CAP2 study, and Mohammed Mavedi did a very nice analysis and confirmed what is recognized in the literature, of course, that obesity is a major risk factor for colon cancer. But what people sometimes forget is just because you've got Lynch syndrome doesn't mean it goes away. In fact, having Lynch syndrome and obesity is a combined effect. In fact, the effect was even greater in this population. But what was also interesting was that the impact was most obvious in the placebo group and was non-significant in the aspirin group. And I put it in here to emphasize that quite possibly this is pointing us towards an anti-inflammatory effect of obesity, the pro-inflammatory effect of obesity being reversed by the relatively high dose of aspirin we were using. Mark has told me that the CCFR data doesn't show this effect, but of course that's mostly looking at low-dose people. I expected Mark and Laney to show the data that they've looked at in Lynch syndrome, so just to report, if you haven't read it, that they've got almost 2,000 Lynch carriers in the CCFR, and they had a very dramatic effect of both self-administered aspirin and ibuprofen, with a hazard ratio of about 0.25 for those on long-term treatment. So we still don't know what exactly is the mechanism here. Is it the pro-apoptotic effect that we know that salicylate has as a natural agent in plants, in helping plants defend themselves? And could it be that this is a pro-apoptotic effect, which fits with the delayed onset, in the sense that an apoptotic process would take out stem cells that were pre-malignant and then stop you getting cancer 3 or 4 years later? Or is it an anti-inflammatory effect, or is it some combination of the two? So we decided to do another study, but actually I put this slide together for the American Gastroenterological Association when Rick was president, and he very kindly invited me. So just to emphasize the point I made earlier, if we found 100,000 people and we put them on aspirin, then it would cost us a couple of $1,000s to prevent the cancer, which is very, very little indeed. But of course the downside is you would cause some bleeds, perhaps 100 hemorrhagic strokes, although probably less than that in this younger population, and perhaps 1,000 extra significant bleeds, so not a trivial impact. On the other hand, you do 1 million colonoscopies, you cause 1,600 bleeds, 700 perforations, and 70 deaths. Now, good colonoscopists wouldn't do that, but this was data, these are papers based on standard screening colonoscopy. That's what you're going to get. So I'm not saying we shouldn't do colonoscopy, but we should perhaps lighten up a little on aspirin. It's about the same as colonoscopy, and we could use the two together. And of course, if you're taking out some of the ascending colon polyps with your aspirin, that reduces the number of polyps to remove by a colonoscopy, and therefore probably reduces your perforation rate. So we started another study to do the dose inferiority study. We argued for a long time about the title and then settled on CAP3. CAP3 is a dose non-inferiority study. We're open now in Finland and are opening in Israel and Australia, but we're basically targeting the UK, and these are all the centres in the UK, and Newcastle is marked for those of you who don't know where it is, and it's not in Scotland, and Scotland still is in the United Kingdom and in the European Union. We're not quite sure whether it'll still be in both in the next 2 years. So at the bottom there is, it's rather confusing that basically we are giving people dummy tablets, but there is no placebo group. So you get a mixture of 2 standard aspirin and 1 baby aspirin, which may or may not contain aspirin. And by combining those together, you get different combinations to give you the 1, 300, and 600 dose. We've managed finally to open outside of the UK. It was much harder than in CAP2 because of the new regulations that are in place. But our 2 most stalwart recruiters, JP Mecklin with Kirsty Pilvenainen in Finland and Finn McRae at the bottom there in Melbourne, have managed to get the study through their respective systems. And Nadia Arba, who you'll all be familiar with in Tel Aviv, is also just about to open there. So we're getting recruiting outside, but it's a much harder system now, and CAP2 would no longer be possible in the modern era. The other problem we've run into is the logistics. Bayer gave us several million free aspirin, but according to the European Clinical Trials Directive, it had to be packed by a procurement system which cost $1 million. And so basically, not only that, you can't change the sell-by date on tablets like we did in CAP2. So basically, a large number of these boxes will go out of date before we get to use them, and we'll have to throw them away and make another $300,000 worth of boxes. So it is a bit of a challenge. Carlos Petrona persuades us to use BD dosing, and I sort of wish we hadn't in a way, because I think the evening dose gets missed quite a lot. So that's going to slightly weaken the number of people who actually took the 600 milligrams. On the other hand, that's a pragmatic reality. If you put people on 600 milligram tablets, they won't always take them. So this is where we've got to so far. We set off, once we get all the centres open, recruiting at about 45 recruits per month with our target of 1,500 in the UK and 500 outside. And we're now just over the 1,000 mark. Because we can't go quite as big as we hope to do 3,000, but we've now cut back to 2,000 target, which will finish the end of next year. But in order to get maximum impact, and looking at the latest CAP2 data, we've done a major trial modification. So instead of just treating for 2 years blind and then following on a cardio dose, we're now actually asking people at their 2-year follow-up to accept to stay on whatever dose they've been randomized to, open label. Now the downside of that is that we lose the blinding. In CAP2, the people are still blind. So the data we've collected over the last decade is very clean in terms of capturing information. On the other hand, these patients are being run in mostly in Britain, where we have an obligatory cancer registry. So we've got them all consented, and people don't keep secrets about having cancer. I've got to move on. I've only got a minute left. So we've now slowed down, unfortunately, because of our 100,000 genomes project. Very briefly, 10 seconds, just to say we've developed a new MSI test, which will cost less than $50, and it'll run on a MySeq, and basically using a combination of shorter repeats, more of them, linked to an informative SNP, which can differentiate noise from signal. I was asked to talk about vaccines. I'm going to do vaccines in a minute. So this is Magnus von Knebel-Döberitz, who's listing in on the screen, and Magnus gave me this slide several years ago. He's been working for a long time on the idea of the frameshift peptides. Basically, if you shift your repeat in the TGF-beta receptor 2 gene from 10 to 9As, you get a different amino acid string thereafter, and that's called a frameshift peptide. Go down to 8, you get a different one again. These things leak out and cause an immune response, and this is Matthias Kluwer, who showed that the MSI-high tumors have a lot of these antibodies, but excitingly also people with Lynch syndrome also have these antibodies, even if they've never had cancer. So that raised the possibility this might be a biomarker of cancers that never quite got off the ground. And so we're collecting and studying this with Matthias and Magnus in the CAP3 study. But Magnus and Matthias have also gone on and identified the 3 most common frameshift peptides to use as a vaccine. And they have actually done phase 1 and phase 2 studies with these 3, injecting these 3. And I don't have time to summarize, except to say they get both an immunoglobulin response and a CD4 response with this as a vaccine. The downside is it's very hard to get enough signal, enough epitope into the system if you simply give the peptides. And so for the several years we've been talking with Ricardo Cortese's group at Okairos The idea is to use a viral-based system where you put your frameshift peptide DNA into a virus and you then give a viral injection. And we couldn't get funded for this about 5 years ago, but then Ocarius went on and made the Ebola vaccine, and everybody knows that that works. So now we're back around, and the team have now come out with a new company to develop a cancer vaccine based on these two viruses. And these are very safe, been given to several thousand people without ill effect. And the idea is you stick your string of frameshift peptides into the virus, give the person the viral infection, they then generate antibodies to all the frameshift peptides, and in theory that should then make them more immune to these tumours. That was a very rapid whistle-stop tour through vaccination, but I hope you got the general drift. We're struggling to get funding for this, but NCI might like to step into that gap. These are the people who did all that work, including Matthias Kluwer on the left there, who is our partner in CAP3. And these are the wonderful people led by Jill Borthwick, who run the CAP3 study. And that's a picture of salicin from willow tree bark, which just won a prize. And in summary, latest data indicate a strengthening case for aspirin. The CAP studies are a very good way of testing that as a cancer endpoint. CAP2 showed that there is an impact, and CAP3 will test 3 different doses on 2,000 gene carriers, blind for 2 years. We then have a bioresource to look at frameshift peptide antibodies, and we'll also be looking at pharmacogenetic variation. And you can follow me on Twitter. Thank you for your time.
Hello. So I'm Larry Brody. I'm about to break one of the cardinal rules of scientific presentations. I'm going to follow an Englishman with a sense of humor. And so I won't try to compete, but we'll see how it goes. So we're changing gears a little bit and talking about essentially the ethical, legal, and social issues related to this potential proposal as was written up in the Blue Ribbon panel material. It's actually quite comforting to see that almost all of what I'm going to say has already been said in snippets in various talks, which was not what happened when we first started doing genetic testing. We would do genetic testing, we say, oops, we forgot to deal with some of the ethical issues up front. I think we've now moved into the environment where everyone realizes that in order to be successful, both with the science as well as with the population, you have to address some of these issues as you're doing the studies. And in our division, we do more what we call embedded LC research, where the trials essentially include LC research going on at the same time. Some of you may think of LC research as something that's more like this, someone who comes along and tells you you can't do something. And that's not what ethical, legal, and social research is about. It's how to learn from what you're doing and essentially move the science forward. And as a bench scientist, I definitely appreciate this side that says, I really want to do something. Can you tell me how I can do it in an acceptable fashion? I'm sure most of you have had a chance to read the Blue Ribbon report. I'll just zero in on the one topic for today, which was to use a proven cancer prevention and early detection strategy and expand how we do this. Very explicitly, the report said this. If we implemented genetic testing, would we have the opportunity to identify families and individuals affected with hereditary cancer syndrome? So I want to emphasize families. It's been touched on a few times today, and the actual economic reports have been mentioned. The real bang from doing this testing comes from when you start looking at asymptomatic people in families. And that's unfortunately where a lot of the complication comes into place. We are talking about a lot of people, again, more quotes from the Blue Ribbon report. Quite a few people walking around who don't know it, who carry hereditary breast and ovarian cancer syndrome genes, as well as colorectal cancer genes. It's been mentioned before, is whether or not these should be paired up into some giant panel or moderate-sized panel. I used to think that both inherited colon cancer and inherited ovarian cancer and breast cancer were examples of what we would learn about every single other cancer. I no longer believe that. I now think that these syndromes are more the exceptions. There are susceptibility genes for lots of other cancer syndromes, but they don't rise to the population frequency or the penetrance in a robust way. So we used to tout that these genes were representative of what we'll learn about the rest of the 22,000 genes in the genome. And I don't say that anymore because I don't think it's true. I think these really are exceptional genes. There are other syndromes associated with them, but they tend to either be of lower penetrance or much less common in the population. And so this was the proposal that was provocatively put in the Blue Ribbon Travel. The underline that I've added to this statement really says the proposal was to screen all people diagnosed with colorectal cancer. And this is on the previous slide. That's a lot of people. I'm going to guess that John has not gotten funding to do that in any of his places, or likely in the U.S. So we're talking about what would we learn from more of a demonstration problem. We've also talked earlier today about the context, and I've heard, there's a lot of epidemiologists in the room who are very strict about when things are population-based or clinic-based or family-based, and I think that's an issue that has to be decided quite up front. I'm going to assume that this is the model that we would be talking about as affected only, but bring the family into it quite quickly. So this would be the proposal. As an individual presents with colorectal cancer, ideally from the bioethics point of view, they would be consented about all this testing up front. We've heard today about some of it being done retroactively. If this is a prospective study, there's no reason to avoid consenting people who are joining the study up front about what might happen with their genetic testing. I realize there is some conveniences that are gained by going back into archives and doing testing outside of a formal consent to be in the study. But this is the person that's in the study. These are really the people who you want to be in the study, the rest of the family. And this is where things get more complex and hit the real world even more. Some families are like this. Very happy if you go to a family reunion. Heather could go to the family. Heather, have you gone to family reunions before? Show up at a family reunion with vacutainers, and you can get a lot of bang for your buck at a giant family reunion. But other families are like this. And I'm sure that most of you remember the beginning of Anna Karenina, where the unhappy families tend to be unhappy in their own way. And so you have to, if you're going to be any kind of large study, it has to take into the realities of family structure from day one, because otherwise you'll be stymied, or you'll only study the happy families, and happy families may be more boring than you would like. So that means having a plan for family outreach that has got some kind of structure. It also probably means oversample. You'll see in a second an example of where the family structure can really help you or can really hurt you in these studies. And so this means bringing in people into these disciplines that don't just deal with affected individuals, but who deal with the unaffected individuals. You probably need to think about alternative sample methods if this doesn't work. I think if the context, I assume we're mostly thinking about a U.S. context, and we'll get to some of the other issues that the U.S. has that other countries don't, but the context really will matter on how you're doing this. The other ethical balance you have to think about is the autonomy of people to be in a study or not be in a study versus what you want, which is you want everybody in that family reunion to give you blood. To the point where, and Heather, you probably have sampled blood from people who were married in, who probably didn't need to be sampled, but they wanted to be involved. And so there is some kind of autonomy, even when it may somewhat degrade the study, that has to be looked at. I'll just give you a quick example of how this might come into play. So here is a woman diagnosed with colon cancer. She receives the consent form, says, yes, I want to be in the study. I want to get my tumor genetically tested for germline mutations, and I realize that it involves the rest of my family. She goes to her brother, who's obviously the most relevant person in this pedigree for looking at prospective studies. He says, great, I will contact all of my kids and let them know, and I'll be tested. Now, for those of you that do human genetics, what happens if we test this brother and he's negative? Didn't tell you this was going to be a quiz, right? Would you do all of his siblings? Right? So it's quite efficient. You test the brother who has a half chance of being positive. He's negative. You don't need to use study resources to testing. How many kids did I give him? 6 kids. What if this brother says, you know, I don't really want to be tested. Right? I just don't want to know. I don't want to be involved in your study, but I'm happy to give you literature to my kids. So now you're testing 6 people. when one might have been all you needed, but you have to accommodate that. No one has to be in a study. Third situation, the brother says, no, go away and don't talk to my kids. What do? We saw in, I think, Dr. Lindor's table, someone had a table of how recruitment was done. Every single study, I thought recruitment was done through the proband. Right? And there are rules and policies about approaching people who are unconnected to the study, but you connect them through their family relationships. And at least in the U.S., and I'm not sure in other countries, it is generally assumed that you will rely on the proband to contact or at least make the introduction to the family members, and you won't call them up out of the blue. So that's a situation that doesn't, in Iceland it may scale where you have complete pedigrees of the entire country. In the U.S. setting it doesn't scale, and I'm going to guess in the U.K. it doesn't scale all that well, and that you have to have this one-on-one relationship with these individual families. Another issue that comes up in a study like this is that we are now saying, and I heard today, testing's almost free, and it's practically free, and it's certainly free compared to what it used to be. And there are elements to the testing that should continue to make it cheaper. I don't think we're going to get down to free, but compared to the rest of the cost of the study, the genetic tests are probably not a major factor. If they're free and they're part of clinical care, is this a research study or is it clinical care? And we've heard about places that do this as part of clinical care. So those people are enrolled in clinical care, they're consented to clinical care. They maybe didn't consent to research. What we're proposing and what's on the table now is essentially a little bit of both. You just heard from John, who had to make sure he had full-on consent to have those people take those aspirins because that was a research study, it was not clinical care. This leads, especially now that information is more digitized and more available, to other considerations that you have to think about. One, these families have to know the difference as to where they are in research and where they're in clinical care. You don't want to make them make the mistake in one direction or you to make the mistake in the other direction. It also involves information. We talked about IT and the savior of all this, and we do in the U.S. We're almost there, we're not there yet, but where information is all digital, but information lives in different domains that are covered by different practices and principles and laws. So shown over here is the electronic health record, which is covered by statutes regulated in the U.S. by HIPAA. The research database, especially if you're doing biospecimens, was covered under CLIA, and for those of you that aren't aware of this, the FDA is trying to play a relatively strong role in approving these kind of studies where there's going to be some kind of intervention, and certainly if you're going to recommend colonoscopy, that's an intervention. So I wouldn't be surprised if the FDA became quite aware of a study like this quickly and have to go through their process. It's probably made more true because now they've been pulled off of the diagnostic, regulating diagnostics, at least for the short term. You also, at some point, there may be information that is shared with the public. When I say the public, I mean publicly available, not that the public is going to be trawling through the information, but publicly available to the research community, as well as controlled access, such as dbGaP. So ahead of time, you want to be thinking about what laws and what principles cover all of these. And I've done these arrows a little bit like equilibrium. I would suspect that a smaller amount, only a subset of information that's gathered on the research side would go back into the person's medical record. I would hope that all the research information goes to be made available for other researchers. The research subjects and study participants need to know that. Also, there is a very strong push now for the information that is gathered in research studies to always go back to participants and make it available. This is codified even more by the Precision Medicine All of Us program that many of you know about, where a guiding principle is that people who participate in that study will have available all of their data. And if they sequence their genome, they're going to be able to get their genome back if they want it. They're not going to get their genome interpreted, but they're going to own that data. So any study like this needs to be cognizant of those principles. The other issue that often comes up, has been already touched on today, is diversity and representation. equity. And so I picked this, for those of you that can't read the Time magazine cover, actually I can't read it now on here. It says, take a good look at this woman. She was created by a computer from a mix of several races. What you see is a remarkable preview of the new face of America. And I think Stan might be blocking the thing. That was a Time cover from 1993, which was actually somewhat stunning how far we've come or not come with regard to the new face of America. Regardless of that, any study that's done has to take into account, if it's done in the U.S., the diversity of the population, both socioeconomic, educational level, as well as ethnic. All of these groups, and we are not yet homogeneous. All of these groups come with their own issues of customs and ethics that need to be accommodated. One of the other issues you have to worry about that was discussed with the variants of unknown significance is that, and the secondary or incidental, there was another term I just heard in the last talk before mine, peripheral findings. It's not an ethical problem. You just need to anticipate and communicate with the people who are in the study these potential issues that will come up, and to also be ready to be wrong. Right? We're going to get some of the interpretations of these variants wrong. We're never going to have a perfect genetic test. We're going to miss genes that should be on there. There's going to be genes that we interpret incorrectly. Knowing that and preparing a study or preparing some kind of project that includes that will get you way ahead instead of trying to catch up later. And then finally, the other issue that you want to keep in mind is informed consent. It's kind of a contract between the investigator and the study participants, and you have to decide how long that commitment is. You're going to be potentially interested in these people for many, many years. I think John's example was the first study I've heard of where it was definitely planned to be 10-year studies. And here at the NIH, we tend to do 10-year duration studies by accident almost when we can't resist them. We rarely plan 10, 15 years in advance. These kind of investigations really would be best powered if they have 10-year follow-up or 15-year follow-up, and obviously people are going to fall off and you have to keep in touch and keep them informed. So I just touched on essentially the kind of things that you want to be thinking about as you're trying to decide what this is. This is different from research opportunities, and I'm just going to put these up here as research opportunities that would arise in a study like this or a large project like this. You know, how do patients understand this material? We've already heard it differs quite a bit across from patient to patient. We don't yet understand, and there are people in this room, there were people in this room earlier who study family communication, how families communicate, and often the person disseminating the information of family is not who you would think and may not even be genetically related to the people who you want to test, and so you have to be aware of those things. Healthcare providers, we saw the very poor uptake as you went down more out into the community. Well, guess what? Most healthcare is not given in tertiary care academic research institutions, and so we have to get better at empowering and educating and drawing those folks in as partners. The genetic stigmatization issue is not going to go away. I think it's with colon cancer and inherited cancer syndromes, we've come a long way to worrying about, we don't have to worry as much about creating an underclass. We've had several talks where people started to look at the cost effectiveness. Screening in Lynch syndrome, especially in the unaffected families, is one of the few things where the cost effectiveness seems to be pretty well established. And that's great because we do a lot of, we put forward a lot of things in medicine that are often have no clinical utility and are not cost effective. And so if you're going out of the gate where you think it'd be cost effective, that's quite good. I brought up the issue of whether or not this should be a Lynch-only kind of effort or a Lynch and hereditary breast and ovarian cancer effort at some point. That would be something to discuss. In the U.S., we have a law for now that says you cannot discriminate on employment based on genetics. Families out there don't understand that, and so we have to understand and be able to take these study participants who might not join your study because they're worried about losing their job, even though it's legally protected. That's not exactly well understood. We also have, for now, an Affordable Health Care Act, which also protects these people in their ability to gather health insurance. We do not have protection against life insurance, and a lot of participants will bring that up. This fear is probably more potent than the reality of actual discrimination, but we've not yet mastered on how to deal with the general public on that. So I will just close with these research questions that could potentially be embedded in some kind of effort such as this, and it was really gratifying to hear all of you that are doing research who have somewhat embedded some of these things already. And so with that, I'm going to close, and I think I was on time. Yes.
Much. I think we'll take a couple of questions, but I actually had a first question for Dr. Brody. One of the questions that comes up in the long-term studies with these long commitments is, what's our obligation and what should we do in terms of reinterpreting data and redistributing that data to patients that were tested years ago, especially in the context of a study like this? What's our obligation? We obviously want to do the best that we can, but sometimes we're also limited by resources.
So, I mean, obligation sounds like a legal question, and I'm not a legal scholar. I think there's probably minimal legal precedence about what you actually owe these people. I think the obligation really derives from what were the conditions of the study and what were folks told. We do lots of research about secondary use of samples and follow-up studies, and universally people are happy to do that, but they want to be informed and asked. So if at the enrollment of the study, they're told that you will be followed up and maybe recontacted a decade from now, or if there's something significant change, we will call you, then you live up to what was in the original agreement. If there are studies where it said, give us your blood, we're never going to talk to you again. That's also fine. The reinterpretation issue will be a factor for any genetic study where you're doing sequencing, where you're getting variants where you're just not 100% sure, but you want to make the call. And so I think really the only obligation is to live up to what the implied agreement was, or the very explicit agreement was when people joined your study. You should also be prepared, and Don Hadley is in the room, who's studied Lynch families for years and years, for these families not to even remember what the results were. And so there is some obligation to keep the records as well, going forward. I don't know if anyone studies the legal aspects of this who might want to chime in. Go ahead.
Hi, Pat Lynch from MD Anderson. I have a question for Dr. Brody. It's, well, a comment and a question and a plea. Heather very nicely reminded us that the cost effectiveness of detecting a mutation in the first place is directly proportional to how many relatives can be identified and benefit from the fact of that. And Megan Myers pointed out that they have a program at UCSF that enables families to communicate with each other online. But in a conversation I had with her several years ago, she basically said we really weren't able to make that a provider-mediated mechanism because our compliance lawyers basically said they were afraid to death that it would violate HIPAA if we got involved and so forth, if I remember right. And we put together a framework at our institution with a lot of great help from our compliance lawyers to try and tackle the HIPAA issues straight on, so that with appropriate consent from index cases, we could do a provider-mediated outreach to family members with e-consent and authentication and so on. My plea really is, my concern is that such battles would have to be refought at every single institution, with different institutions, different IRBs arriving at different conclusions about what we could and couldn't get away with. Because HIPAA is a federal law, my plea is that the NIH people in the room gather up the HIPAA ethicists, the HIPAA lawyers, and the people that work with them, put them in a room and don't let them out until they've helped come up with a construct that will provide guidance to the very cautious, conservative compliance lawyers around the country that are trying to make sense of how HIPAA and related regulation and, regulations impact their ability to do what they want to do. Otherwise, I don't think any kind of, at least provider-mediated outreach is ever going to be successful in the U.S. We have to have federal guidance. Now, my last comment is, federal has become a dirty word, and states like Texas will push back hard and say, oh, we've got to do it our own way. We don't care what the feds say. Yet HIPAA remains a federal law, and at least as to HIPAA, we have to have federal guidance and clarification.
So I certainly agree with you. I don't know if I can round up these folks. The legal people we work with in fund will often say, well, if you're sued and you win, that's the way to actually make it happen. I'm not suggesting someone sues your institution and you win. I don't know exactly how much play there can be in the HIPAA statute and guidelines as written and who we could influence as the NIH. NIH is not a legislative body. It's a we can come up with recommendations. We do the same weird, quirky workarounds to avoid actually government rules, sometimes even on our own websites. Maybe I shouldn't say that out loud, where third parties can do things that we can't do. There would be an alternative way to do that would be to have some third party step up and create this platform for all these exchanges. Strangely enough, the government could fund that, and your institution could be at arm's length, and it would make your lawyers happy. Lawyers are definitely very conservative, and institutional lawyers are the most conservative of the lot.
Ned Collins from Colorado. That was yet another fantastic panel. Appreciate the insights and how the information goes together. I feel an ongoing need to make the comment about potential harms, because I think I've heard a lot of different presenters talk about doing more testing. And I agree that more testing means more opportunity for benefit. And as Sir Byrne said, more testing gives you more opportunity for harm, especially as we start moving into low penetrance genes. So in the BioWatch world, we call them biologic false positives. In the cancer screening world, we'd call them overdiagnosis. And in the genetics world, it's kind of low penetrance or variants of uncertain significance. I think we always need to keep an eye on the fact that if we test more, and especially as the penetrance goes down, we need to be ever cognizant of the research gaps that talk about the harms of colonoscopy and the harms of aspirin as we start to address these patients. So we just keep that same zeal for considering harms as we think about the benefits. I think we'll make better overall decisions. Thanks.
Finley McRae from Melbourne. I just wanted to comment on the INSIGHT DNA mismatch repair database, which is mentioned, Zsofia mentioned it well. It's still alive and active. It depends on submission of variants and annotated information for its work of determining pathogenicity of the variants. It does do well in Europe in terms of ascertaining variants from national sources of DNA, of the variants in several European countries and Australia. America's not so adept at submitting the information, although admittedly we do work closely with ClinVar and achieve and share our experiences with ClinVar. The INSIGHT committee is actually the ClinGen committee overseeing the mismatch repair set of variants in ClinVar, so there's a close collaboration. So I guess it's a plea. The best way to understand variants is an international resource that has access to wide information. Recurrently, we find in our Variant Interpretation Committee that members of our committee, and indeed the broad INSIGHT community, can produce information which actually transforms the interpretation from information they have held not necessarily published, often not published, but critical to the interpretation. So it's a great resource, and we know it's used, 60,000 hits per month for information about variants. I encourage you to submit and include annotated information that allows us to move forward with the classification process.
Can I follow Finn's points up? I guess was one of the midwives of the Insight database when I was president of Insight 10, 15 years ago, but Finn individually has been remarkably effective in keeping it alive and getting it funded, and it is a hugely important resource. And I would actually go further than Finn. I think that we need to start thinking in a regulatory sense that diagnostic laboratories should be obliged to release variant data into these databases so we're all singing from the same hymn sheet. One of my colleagues, Naz Rahman, calls VUS as very unhelpful statements. And you know, I think we shouldn't underestimate the damage done by telling someone they have a variant, we don't know what the hell it means. And you're just creating an awful lot of noise. And so I think we need to really pull together to get to minimize this. And the other point that was raised in the earlier slides, that in fact, if one person's calling it a VUS and someone else is calling it pathogenic, someone's going to get sued, someone's going to die inappropriately. So we have to all sing from the same hymn sheet. And I think we need to concentrate on this. And Larry and I are involved in the BRCA Challenge, which is very much driving down that same road to try and get a single database, pulling all the information from ClinVar, from LOVD, from BIC, etc., into one place, getting it properly curated by an expert team, and then we all can refer to that same database. So I think there is a commonality between breast cancer and bowel cancer. It may well be politically beneficial to keep them apart, but what we have to think a few years down the line, we'll look back in amazement that we were doing this without a reference database of what was pathogenic and what wasn't. And I think that's something that maybe NCI needs to think about, how it drives that agenda forward.
Hi, I am Rebecca Ward, and I have Lynch syndrome. I'm a 7-year survivor of stage 3C uterine papillary serous carcinoma. I'm also a nurse and a mother. And one of the things I wanted to encourage you, everybody in the room who's a provider, is to reinforce Dr. Brody's slide that says healthcare provider involvement. Because I believe that even though my family members have chosen to not be tested, it's highly likely that down the road, if they did decide that they did want to have testing, they would not be reaching out to an epidemiologist or to a genetic counselor. They would be going to their primary care doctor, maybe their gynecologist, dermatologist, and saying, oh, you know, my sister told me a while ago that she had Lynch syndrome. So I think that involvement of the provider community is really important, because I can't tell you how many times I have gone to a new doctor, and said, I have Lynch syndrome, and they kind of surreptitiously pull up Dr. Google and put it in there, and I have to do the education. I have to teach them what it is, and I have to manage sometimes my own care. So I think involvement of primary care physicians is a really important piece of this.
We just published a survey that showed 1 in 3 of the primary care clinicians in Britain had never heard of it.
So we have one from the outside, from the ether. It's actually a series of statements, not questions, but the last sentence I'm going to direct toward Larry. So this says, to follow on Dr. Lynch's comments, inclusion of patient advocacy organizations such as HCCF, LSI, and Alive and Kickin' in designing and implementing a study would be mutually beneficial. We can reach a broad audience with less bureaucratic control or bureaucratic inhibition, i.e. HIPAA issues. So I'm interpreting the question to be, if you've got advocacy and patient involvement, are we more likely to soften the HIPAA rules?
You mean actually to get the government to soften them, or just to essentially have the advocacy groups go around them because they're not bound by them? I mean, I think that's what we see, especially for the rare disease community and a lot of other inherited diseases. The advocacy groups are driving and moving the research forward because they're more nimble, a little bit less bureaucratic, and not bound by a lot of these sharing, especially from the medical record rules. So, I mean, I would agree with I don't know about these organizations, but I would agree that you'd want to have them be partners. You'd want to be careful that some of these organizations don't have as much outreach to more diverse populations as you would like in a study design like this. So that would also be a factor. I think John mentioned that the studies they did were, at least in our institute, and I believe in the NIH as a whole, we're now seeing the value and starting to figure out how to fund federally qualified healthcare systems and people in community hospitals to learn more from what I would call the real world setting, not to insult all the people from academic medical centers. So I think that outreach is going on both to the advocacy community as well as to the general healthcare community.
Hi, my name is Georgia Hurst. I'm the founder and executive director of IHaveLynchSyndrome.org. This question is geared towards Sir John Byrne. I have been on aspirin therapy now for 5 years. I was finally diagnosed with a polyp last year. Unfortunately, they also diagnosed me with Barrett's esophagus. Are you familiar with any connection between taking a high level of aspirin therapy and Barrett's esophagus? And what would you recommend for someone in my position who's a pre-viver do? They told me to lay off of the aspirin therapy for a while until the Barrett's calm down. I won't know anything more until May.
Keep taking the aspirin. Janusz Stamkowski's been actually running a big trial in Barrett's and esophageal, well, in Barrett's of aspirin, but the general perception is that aspirin reduces esophageal cancer as well, and Barrett's is a pre-malignant lesion. So the answer is it's probably nothing to do with your Lynch syndrome, but there is no logic in stopping your aspirin because of Barrett's esophagus.
Thank you.
Is that clear? Yeah, I mean, one of the interesting things we find there's an awful lot of stories or information coming out about using of aspirin, which I've learned about. So, for example, if you're on sodium valproate, it displaces it and gives you a higher dose, so you can get toxicity. So there are all sorts of effects of aspirin, which it's not a trivial drug, but generally speaking, people are very tolerant of it, and it's only really the old and frail and hypertensive who are in the very high risk group, and we shouldn't just generalize the risk. It's actually, for most people, quite low.
Rick Bolin, San Diego. I have a technical question for Stan. It's surprising to me that immunohistochemistry works as well as it does. Because
surprising to me too.
But for a technical reason, I don't mean to suggest you can't do it, because I know you can do it. But the question is that for that to occur, both the first hit and the second hits have to be totally destructive of that protein, which seems unlikely, right? And so I'm surprised that it works as often as it does, because there are a lot of missense mutations around. And I wonder if one of the reasons why we don't diagnose MSH2 and PMS2 Lynch syndrome as often is if it's because maybe there are a lot more missense mutations. And even though there might be microsatellite instability, because we don't do that very much, the IHC may still look intact. And I wonder if the pathology world has ever looked at the relationship between where the mutation is and the stability of the protein. You can lose the enzymatic activity of the protein and not lose the immunogenicity. And at least for APC, any mutation that's more than 1/3 of the way down leaves you with a stable, if not functional protein, which is probably why we don't use IHC for FAP.
Yeah, that's a great question, Rick. And I don't know that anybody specifically looked at that and published on it. We have a paper from about a year and a half ago that Angela Bartley, our fellow, had written, doing the immunohistochemistry in cases that have been evaluated by microsatellite instability, and showing that the predictive value of a positive is almost 100%. In other words, if you've lost the protein, it's almost guaranteed that microsatellite instability is present unless it's MSH6. MSH6 is the rule breaker on that. That there are cases that have lost MSH6 that do not have microsatellite instability. I don't understand that either, but that's what the study showed. On the other side of the coin, where immuno usually falls short is in the situation exactly as you described, that the protein is retained, but the tumor is microsatellite instability high. And that obviously relates to the functionality of it. I don't know anybody who's really gone in and looked in any detail, but the other thought to this is it has something to do with the fact that the ubiquitination pathway and the proteasome degradation somehow recognizes that that protein is abnormal and takes it out, clears it anyway, and that's why it goes away, even when it doesn't necessarily look like the epitope that was seen by the antibody was gone. So I don't know. Long answer to say I don't know.
And also,
it's a great question.
If you lost the enzymatic activity of MLH1 or MSH2, then every now and again you see the isolated loss of MSH6 or MS2 that's due to the other protein.
Right.
And if it happened the other way around, you wouldn't see it,
right,
which might account for our problem with those. Anyways, and John, I have a question. It has to do with, we showed some number of years ago that in vitro, when you add aspirin, you increase the stability of mismatch repair proteins. And I wonder if you thought any about how that might be part of the aspirin thing. Also, oxidative stress using either, there's a couple of different ways of doing it. You can use hydrogen peroxide, or you can use some other ways of adding oxidative stress with iron and so on. We've done it both ways. And that reduces the mismatch repair proteins and the repair activity, both.
The short answer is I have no response. I was unaware of that effect at cellular level, and that's very interesting. The one thing I would say is that a lot of people who are experts in aspirin keep saying it has to work through platelets. It's got to be something to do with platelets. And clearly that might explain why one of the reasons you don't metastasize, though losing B2M is probably more important. But I think, what we have to remember is that salicylate was a normal part of our natural diet. If you're on the old paleo diet and you fed in the forest, there was a lot of salicylate in our diet. We actually fed some medical students sort of wild food and stuff, and you could actually raise your salicylate levels quite substantially if you eat wild food. But anything that's being farmed has no salicylate because it has no pathogens to drive salicylate production. So the point of that story is that probably our entire system evolved to expect a bit of salicylate to be around, and it almost certainly has a role, as the classic vitamins do, in lots and lots of different pathways that we don't fully understand. So I think I'm not at all surprised. I think the more you look at pathways without salicylate, the more you'll see them having an impact. What it means, I'm not sure, but I think to suggest it's just about blocking platelets is a very narrow view.
We did a study some years ago with Dean Brenner when I was at the University of Michigan, and we were looking at the effect of single doses of aspirin on cyclooxygenase expression in rectal biopsies. And so we had to use HPLC to zero out everybody's salicylate levels to make sure that they weren't taking any. And one person we couldn't zero out, and she was eating walnuts all the time. So I suppose walnuts are a big source of salicylates too.
Yeah, as was nutmeg. In fact, nutmeg was a fantastic source of salicylate, which is probably why it was thought to treat the plague, which is why the Dutch swapped the one island you could get nutmeg from for Manhattan after the British-Dutch wars were settled.
Yeah, who got the short end of that?
Well, I'm not sure. I think, in retrospect, yeah. All right. I just one last thing. I just want to attack Stan on one slide. Otherwise, it's a fantastic presentation. But both him and Zsofia used that pie chart we keep seeing over and over again. The pie chart's wrong, very fundamentally wrong, because it gives the impression that 30%, there's the 10% that's monogenic, then there's the 30% that's genetic, then there's the rest that's sporadic. Actually, that 30% was about heritability. So all of the other stuff has 30% of the cause is genes, and the rest is environmental. And that's I think we can keep separating them incorrectly. Everybody's got a bit of both, even the monogenics, as we showed with the obesity data. So we're probably incorrectly segmenting this and looking for monogenic things that aren't there.
Fair.
Well, thank you again for the very good session. Now we'll have a break, about 20 minutes break for coffee, and we'll meet back at 3:15.